So I think that's the main effect there,
Yeah.
and that helps with DSD. You don't worry about dinging the
Trim this back
muscle. You
up,
don't
right?
get
Yep, flip open.
post-polypectomy syndrome, etc.
And I
In fact,
think
Jeff,
you
it looks like
said
you got
right.
most of
We
the
have to
fibrotic
pay.
area
Yeah.
just with that.
Close a little bit. Stop. So I'm just going to trim this back area only because I
Yeah.
can't be 100% sure that there wasn't a little bit of adenoma there. Close, 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 close. Good.
So,
Ready?
Jeff, so
Good.
Stavros was mentioning Ken Meller. I think we need to pay tribute to him because he reported first underwater technique for large colorectal polyps in 2012 in GI endoscopy.
Open.
And this was one of the big revolution in the field of therapeutic endoscopy.
For sure. Yeah, I mean, it totally changed the landscape as he has done now a few times. So I'm going to try and get this piece here, which is going to capture what I think is the remaining bit of the lesion.
And I
And
will
I don't
not be
mind
scared
taking a
to
nice
take a
big
big
piece
piece.
here in order to make sure that I'm grabbing what I want to grab. Close a little bit. Stop.
I don't know if everyone agrees,
Close,
but
close, 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 close,
if
close,
this was
close.
done conventional EMR, I think it would have taken a lot longer.
Ready?
It would have been a lot more challenging than what you've demonstrated so far, Jeff.
What I find amazing is the difference in feel of the cut with EndoCut U versus standard. And oh, we left a little piece.
Hot avulsion.
Yeah.
Close. We were so close. Doesn't mean we're not going to get it, but we're so close. So I think now our snare is too big for this, and so our options are what, Sunil?
Cold avulsion.
So you can choose a smaller snare. Under saline, this may still lift up, and you may be able to capture it.
Yeah.
Other options include using adjunctive techniques. Because it's so small, you could consider submucosal release with the snare tip.
Yep.
Equally, you could do cast or hot avulsion as well, given how small it is.
Yeah.
But I think, given how nice of a plane you have all the way around this, it's suctioning well. You're under saline. My first port of call would be to use a smaller snare.
I think
See
so.
if you can grab it.
Yeah, so we're going to pivot to a smaller snare. We're going to use a 10 millimeter Olympus snare, Olympus hot cold. And the reason I like that, number one, is it's a little bit thinner, and it's good if you end up using it to release the mucosa, which again is often my approach of choice. Then it's good for that too, because it's a bit lower current density. I mean, a bit higher current density at the tip. Because of the size. So the Captivator I don't like for cutting, but this is nice for cutting. And so we're almost done here. And so yeah.
Hey, Jeff, can you hear me?
Yeah.
So
Welcome,
question
boss.
for you. Some experts do a hybrid technique, which means they inject
Yep.
just like a blue dyed saline and then go underwater and do the resection. Does that eliminate the benefits of underwater EMR?
Yeah, great question. I think the answer is that in resection, you have to be prepared to pivot. And so I'm always selecting a strategy and then pivoting based on what I think is working and what's not working. And the example here is that I'm not sure I'm going to be able to grab this tissue. I'm suctioning to the best of my ability. So do I think that a hybrid technique would have worked for this? 100%. I would have made a circumferential incision. So probably a year ago, what I would have done is injected around, done circumferential incision, and then gone after it with standard EMR. But I think the underwater here like obviated the need for that, right? Like we were able to get a margin, and so it's as if we did do a circumferential incision here with EMR of the margins.
Yeah,
So
Jeff, sorry, let me clarify the question. I meant inject, like submucosal injection.
Yeah.
Then do the resection. You know, with the underwater, classic underwater EMR is what you did. No submucosal injection.
Yeah.
Maybe Stavros, you can help us answer that. He's busy with that central scarred area.
Well, I actually don't think it would have helped here. I think it would have actually made it more difficult because parts would have lifted, parts wouldn't have lifted, and so it actually would have made it more complicated. What do you think, Mohan?
No, I'm not saying for this specific lesion. We're just having a more general discussion now. Underwater EMR.
Got it. Let me say one thing before you answer that question. So I've suctioned significantly before when I grab this, and so Kaylee and I are emotional. You can't see her; she's off camera, but her and I and Sunil, although he's pretty cool and calm and collected, are emotionally prepared for making a hole here. And so I tell everyone in the room that there's a
Emotionally.
decent chance that we might make a hole because
Very
I've
small,
suctioned
very small.
potentially
This is safe.
muscle here. I don't think it will,
No.
but I'm prepared if
It's
it
good.
does, and
I
I'm
was-
fairly confident that
yeah.
we'll be able to close
And
it.
Jeff,
I
would
was
you still
making
cut
a
underwater
face
here,
too
or would
about
you
that,
suction underwater
yeah.
and then do the cut if you're worried about a perforation or
Yeah.
a hole?
Why
Yeah,
do
we
you
might
ask?
get a hole here.
Well,
Yep.
you're just going to flush all this fluid into the peritoneal cavity if there
Right.
is a hole. Although it's pretty clear,
Yeah.
given it's probably going to be your last cut, would you do that?
Yeah, it's a good question. What does the panel think? Take the water out now?
Not a bad idea.
Oh, Davros agrees with you. That's good. Well, that's a win for
That's
you.
a win.
I've done the suck and snare technique on scarred area for the last 15 years. You get the perforation if you suction non-scarred area in the snare. It's very hard to suck muscle into the snare.
Yeah.
And
again, I agree. I don't
I think
that's
you're
gonna
very
happen.
specific with
I'm
this.
just preparing.
Yep, go for it.
Emotionally.
And you're fine.
No excitement. So now we can examine the area. We'll examine first underwater, although I'm not sure that's necessary. But the underwater gives you some magnification at the margin in order for us to make sure that there's no adenoma left over. And what do you think in hindsight? So I always review with our fellows, and we review with each other about what we thought about our technique and how the underwater helped here. Sunil, what do you think? Did you like our approach? Would you have done anything differently? Because I think in just a minute we're going to get cut off with some more impressive videos that are to come.
So I think we were set on doing a piecemeal technique. We thought, there's no SMIC here. It's reasonable to do EST, but also reasonable to do a piecemeal resection. And then I think in terms of choosing a technique, underwater was the best way to go here. You really nicely demonstrated you only needed 3 or 4, grabs to really resect the whole specimen. A saline injection would have lifted certain parts of this, other parts not. You would have required some other adjunctive techniques to complete that resection. So I think this is the nicest, cleanest way to do it. As to the question about injecting into the submucosa and then doing underwater, I think that also would have hindered you because the lesion in the submucosa would then not have lifted up nicely away from the muscle.
And you can actually tell here what might have lifted and what wouldn't, right? You're getting some submucosal lift and injection here by just flushing saline into the defect.
Yeah.
So I think, and that center clearly wouldn't have lifted. We would have needed to cut that out. So,
Are you
panel,
going to
what do you
close?
guys say?
Are you going
Number
to close
one,
this?
what do you think about the technique? Number 2, how did you like EndoCut U? We're going to talk about that more. And then anything else you do to this lesion? Do you think it needs snare tip, soft coagulation to the margin?
So
what about closure?
Jeff, let me start. You did a wonderful job. So that was probably best solution, probably better than ESD. 7 times, very safe, very carefully done. So congratulations.
Thank you.
Second, there are 2 main questions to the experts. One is we need to make a margin ablation to reduce recurrence, even though you have been very large, very generous on the margins, so we can't see any adenomatous tissue left behind. And the second question is, do we need to close because it is larger than 2.5 centimeter defect in the right colon, and based on number of prospective studies, this is a lesion that has a high risk of delayed bleeding. So I want to ask first to Stavros and Muin, and afterwards move to you.
It's not that I don't want to hear your answer, but I'm going to proceed with our standard while you're talking.
Yeah, okay.
Okay. Well, I'm not a believer in your standard, but go ahead.
No problem. Not everyone has to be.
So no, I'm a 2 thumbs down on that. And there's evidence in the literature that supports my view. And number 2, I would definitely close the defect because the data, I believe in the data in terms of decreasing delayed bleeding. Yep. So that's my approach.
Stavros, to close this defect with a lot of fibrotic tissue, we should go again underwater.
Randomized trials for both closing right-sided lesions and margin ablation. And, it takes an extra minute to ablate using the same snare. So, and this is level 1 data. So why not do it?
And why don't do
But I
ablation?
also
Why don't do ablation underwater?
well, here's John Day. John, how can we ablate underwater?
It's being done. Yeah, and you can do it. A lot of folks use soft coag with quick start, for instance. There's a quick start setting, but that's too much to go into right now. I need to say something though. I'm very impressed. This is the first EMR I've seen with EndoCut U, and the margins were very clean. It appears you're able to scrutinize them really quite easily from an optical standpoint. So I'm impressed actually.
Yeah, and Jeff, you just
John,
saved
then
2
mission
hours.
accomplished. Time to hang him up. It's only downhill from here.
Yeah.
Okay, great. I think, Jeff, thank you so much. That was very impressive, and we appreciate your involvement. And I think, Stavros, we can move to you right now for your video.
Perfect.
Before moving
Sunil,
to
thanks for hanging out
Stavros,
with me, and
Thank
thanks
you.
for having
before
us.
moving,
And we're going to close this lesion up, and then I'm going to jump online. So thanks, guys, so
Thank you.
much. Really appreciate
keep
it.
recording.
Bye from
Keep
Toronto.
recording the closure. Keep recording the closure, please. Keep recording. We want to see the end. Keep recording the closure. Stavros.
Yes, my video. I don't know. I'm in a hotel in Aruba, so I wasn't sure about the Wi-Fi. So my video is kind of pre-recorded. So they'll play it now from their server, and
Thank
then
you,
I'll
man, for inviting me
rejoin.
to this endoscopyonair seminar. It's great to be here with friends like Ali and John and Jeff to discuss underwater ESD, a technique that has revolutionized my ESD practice for the past few years, particularly in the colon and duodenum. First, some underwater ESD management tips that may not be easy to appreciate in the 2 short case videos that I have. In particular, fluid management. Massive amounts of fluid may be infused during long underwater ESD cases. This is from a Japanese study where you can see up to 14 liters of fluid were injected in a patient. So it's good to be able to manage these amounts of fluid. In Japan, they have saline drainage catheters that attach to the endoscope, and they remove the saline during the procedure, and that keeps the lumen collapsed with a soft wall, which is desirable. Also, you can see as the ESD progresses, for example, in the colon, the aspiration of saline gradually cleans up the colon, and there may be less risk of high bacterial contamination if there's a perforation. In the US, you can jerry-rig some tubes to do the same thing, but a simpler approach is to use the Neptune high suction system. Up to 20 liters can be aspirated before the canisters need to be emptied, and you can pump the suction pressure all the way up to 520 millimeters of mercury, which can rapidly clear the saline if it's contaminated by blood, stool, or bile, and decreases the visibility during the procedure. Also, very important for these large amounts of fluid is to maintain a good patient temperature. A fluid warmer and a bear hugger are essential to avoid hypothermia. This is my setup for underwater ESD. You can see here standing or seated for longer cases with a surgery stool. You can see I have the saline on my right foot and the other 3 pedals on the left. In Japan, they're lucky enough to have techs that can manage the irrigation and some of them even the blue pedal. But having to do all 4 pedals is ergonomically complex, and maybe seated is a better choice. This arrangement allows you to do continuous irrigation with the right foot and simultaneous dissection with the left as is needed in the water pressure technique, which I'll show you on the video. And you can also do continuous irrigation and use the blue pedal, which helps attenuate the blue current effect if necessary, if you want a lower effect on the blue pedal. So this is the arrangement. You can see the saline collection bags that avoid fluid going under the patient and making them hypothermic or soaking your shoes. Important for upper GI ESDs is to maybe use some diapers on the patient, because if you exceed 1 liter per hour, 2 liters per 2 hours of fluid, you can get a lot of incontinence of stool. Now, just 2 slides on electrosurgery, which I think John Day is going to cover better and more extensively. So for under saline ESD, it can be hampered by excessive bubbles, especially if you use thin knives, blue pedal currents, and the Fuji tapered caps, which I prefer. So it's interesting that Yamamoto at the JES meeting in this past September, offered his ideas about bubble-free ESD. He found that the bubbling is voltage dependent, lower voltage, less bubbles. And he recommended soft current, which has a very low voltage to prevent bubbles. For the yellow pedal, also, he recommended a very high effect and a low cut duration. But for the blue pedal, very important, maybe the most important thing is to use a soft pedal, a soft current, which creates much less bubbles than forced or spray or swift or other currents that operators use underwater. Now, let me show you, we did this case with John Day investigating in a clinical setting, endocut U versus I. To scalenize vessels and then coagulate the vessel. I'll show you my technique. So this is an artery. We try to scalenize it by cutting the submucosa, but you see the endocut eye not only doesn't cut the submucosa, but injures the vessel by having a spark that goes too far. Now we try here, same effect. Then we switch to U, and with just 1-2 pulses, the submucosa is cut and the vessel is not injured. Then we choose the blue pedal. In this case, I use spray. That's why there are bubbles, not soft. I massage the vessel because you want to coagulate a segment, not a point. And then I remove the water to increase the effect of the blue pedal. As I said, you can use more water to modulate the intensity of the effect to cut through the vessel. You can actually